the first line therapy.
طيب بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم. Thank you for the organizing and the scientific committee, and thank you for the chairperson for the kind introduction. So the talk is how to improve the outcome of the diffuse large B-cell lymphoma and optimization of the first line treatment. I will start just with the background, just to understand what happened over the last 30 years. This is the first study was published by Fisher in New England Journal of Medicine in 1993 when the CHOP was tested against the three main backbone chemotherapy at that time, which is the MAC-COD and MAC-COB and the PROMACE. And this is a combination of the doxorubicin, cyclo, and bleomycin. In that study, it showed that CHOP is the treatment that was preferred based into the efficacy and less toxicities compared to the other protocols. And then in 2002, Covier from the French group showed that R-CHOP is superior to the CHOP chemotherapy in terms of the progression-free survival and overall survival. And then over the last maybe 23 years from the CHOP or R-CHOP in 2002 until 2022, almost like 20 years, we had the Pula R-CHOP was the first treatment combination showed a superiority to the R-CHOP. We've seen many clinical trials involved a lot of patients testing for example, the dose-adjusted R-epoch, the intensified R-CHOP 14, adding the ibrutinib, lenalidomide, everolimus, and all did not show any superiority over the R-CHOP every 3 weeks. So that's the POLARIX study, which showed a progression-free survival, and that was maintained after 5 years with the hazard ratio of 0.77, so 23% reduce in the risk of progression compared to the R-CHOP in those patients with IPI 225. So from that, we have just only the two chemotherapy now available for the diffuse large B-cell lymphoma, either R-CHOP or Pola R-CHOP, and probably the dose-adjusted R-epoch for a certain high-grade B-cell lymphomas or double or triple hit. So is there any way we can improve the outcome? One of them is maybe to improve the classification at the molecular level, so you can specify which patient might benefit from a certain treatment. Is there a way to identify a high-risk patient after receiving the R-CHOP or the Pola R-CHOP based into the interim PIT or the minimal residual disease, so you can intensify or de-escalate the treatment based onto the responses after 2 or 3 cycles, and then incorporation of the novel agent into the front line. We've seen the talk by Dr. Samira, but bispecific into the second and third lines, as well as the CAR T cells. So can we move them early into the induction part? So I will start with the molecular subtyping of the diffuse large B-cell lymphoma. Alizada in 2000 showed the gene expression profiling, came up with the 3 subgroup of patient, either a GCP, non-GCP, or the activated, they call them the activated B-cell subtypes, based into that gene expression profiling. Despite the inferior outcome between the ABC and ABC, which is non-GCP, and the GCP, but we still treat them until 2026 the same, with the same protocol. So we are not differentiating between the 3 groups based into the gene expression profiling. We have 2 different pathways. The GCP, it works by the translocation or the mutation into the BCL2, into the MYC, into the ZDH. That's different from the ABC, the gene mutation, or and that group is MYD88 and the CD9 7B. And the ABC, it works through the signaling pathway, which is different from the GCP subtypes. That might explain why maybe we've seen the POLARIX study showed a superiority in ABC compared to a GCP subtypes, because it induces that signaling pathway. So because the gene expression profile was not available in the practice, most of our practice was based into the HANS classification, which is the immunohistochemistry, using the three CD10, BCL6, and the MUM1, just to classify the patient to GCP or non-GCP. So we cannot see here, we cannot say APC because it's not a gene expression profile, so GCP or non-GCP profiling. A lot of studies done using that cell of origin based into the immunohistochemistry, including the Phoenix study, the remodel, the robust, adding ibrutinib or bortezomib and lenalidomide. It did not show any progression-free survival benefit based on that classification, except maybe the bortezomib showed a superiority into the ABC, but we know that bortezomib is not one that we use in a diffuse large B-cell lymphoma nowadays. So polatuzumab, it binds to the CD79, and the monomethyl is the payload, and this works on both the GCP and non-GCP. But because the ABC subtypes dependent pathway is into the signaling pathway, that's why we see more effect maybe into the ABC subtypes compared to the GCP. And this is the subgroup analysis. You can see that into the ABC, if you look carefully, those who received the Pola-R-CHP as ABC, the progression-free survival was 85%, which is higher than those received R-CHOP in 56. This is even higher than the Pola-R-CHP into the GCP. So those ABC received Pola-R-CHP, they had a superior benefit compared to the other subgroup. However, this is a subgroup analysis. It was not powered to have that analysis. So what about the double hit lymphomas? We know that our diagnosis into the practice is based into the molecular, primarily into the FISH, to see if there is any c-MYC or BCL2 or BCL6, and we used to call the MYC rearrangement with the BCL2, that's a double hit, and we used to also say MYC with the BCL6 as a double hit, but this is not the scenario now. So the BCL6 categorized now as the diffuse large B-cell lymphoma, and just only the c-MYC rearrangement, BCTL rearrangement, we call them a double hit. If you have the three, this is a triple hit. Why is that important? Because those with the c-MYC and BCL6 rearrangement, they benefited from the Pola-R-CHP more than the dose-adjusted R-epoch, and they should be treated as a high-grade or diffuse large B-cell lymphoma in OS compared to the double-hit c-MYC and BCL2. This is the study by Dunleavy. It showed that dose-adjusted R-epoch into the double-hit. So why we are talking here about the double-hit? Because the molecular rearrangement, it just only showed a small number of that in less than 10%. But there is now a dark zone gene expression. That dark zone, it discovers those high-grade lymphoma are arranged or arised from the germinal center. They have the same genetic mutation as the double or triple hit, but those are missed by the FISH compared to the dark zone. So how many patients in our practice, they have a dark zone, but they have a negative rearrangement into the FISH? We still treat them with the R-CHOP or Pola-R-CHOP. So maybe in the future, any improvement into the dark zone gene expression profiling will maybe have a more patient to be treated as a high-grade lymphomas. This has become presented in many conferences talking about the cluster. There are two now modules or models to classify the molecular from one from Harvard, one from NSI, based into the genetic mutation in each group. So we are not talking here about one group of diffuse large B-cell lymphoma. It's a heterogeneous disease. So based into the B cell classifier, so what they do, they have the molecular, they do the gene expression, and then they classify it based on what are the gene mutated in that subgroup. For example, class 1 and 5, ABC subtypes, because the gene mutation are the BCL6, the notch 2, and into the C5 is MYD 70, MYD 88, and the CD 79. And if you see the name of the lymphogene, they call it MSD. So what is MSD? M coming from MY and the C from the CD. So based on those two mutations, they call it MSD. The same for the EZB. It comes from the EZH and BCL2. So that's how they call. This is equal into the other model to cluster 1, 2, 5. And they discovered that they don't have the same cell of origin. They are different, ABC versus GCP. And there may be a clinical association with the other group, like for the marginal zone lymphoma, they have the cluster 1. C5, you might see the extranodal example, those who presented with the testicular lymphoma with the CNS involvement. And you can see the 5-year survival based into that cluster. So for example, in cluster 5, the ABC subtype, the 5 years is 26, compared, for example, to the GCP subtypes in a cluster to 100%. So this will help in the future to prognose as well as to predict maybe the modality of treatment. This is just only the same. So what is the differences between the lymphogene and the diffuse large B cell classifier models? Into the diffuse large B class gene expression, you can see they may be classified all the group within the C1, 2, 3, 4, 5. But into the lymphogene, there is still about a 37 to a 40% not classified by that model of gene expression technique. So this is one of the main differences. To summarize, ABC subtypes, we have the cluster 1 and 5, and that's equal to BN2 and MCD into the other model. The GCP, we have the C cluster 3 and 4, equal to the EZP and the STAT, and this cluster 2 is between. So we have a group of patients, they might have ABC origin, or a group of patients with the GCP. Again, why is that important? Because this is a possible target therapy will be used in the future based on that molecular classification. And one of the example into the Phoenix study, we remember that ibrutinib was added to the R-CHOP. So when they did a retrospective analysis, they found those patients with MCD, which is the MYD or the CD79, when received ibrutinib plus R-CHOP, the progression-free survival was 100% and overall survival 100%. So maybe identifying those patients with that technique and giving them the ibrutinib, they will get the benefit compared to the R-CHOP. This is the same in the POLARIX study, but this is a small number. When they went back to see MCD and EZP, when they received the POLA R-CHOP, had a superiority compared to the R-CHOP. The guidance study is a Chinese study, and we've seen it presented in conferences. They use the same model of the MCD and the BN2 and the N1 and EZP, and they added other novel agents based into the cluster. In that study, it showed those patients who received addition novel agent based on a molecular classification showed superiority to the R-CHOP, either in progression-free survival or overall survival. But they did not specify which one. They just lumped the whole group. They did not say those who MCD, when they randomized, for example, to POLA R-CHOP or to the ibrutinib, what was their outcome. So they presented just only the whole group. And this is a study, they call it the Lymphoma. And this is the future, is they will classify the patient. At the diagnosis, they will give one cycles, either R-CHOP or POLA R-CHOP, and then based into the molecular classification using one of the C1, 2, 3, or 4 or 5, or the other mutation according to the lymphogene, the randomization will be either to POLA R-CHOP or maybe adding EZH inhibitor or the JAK inhibitors or the BTK based on each classification. So microenvironment, also they identified now two microenvironment, either hot or cold. Mosunetuzumab was tested in a 32 patient. It showed that with the molecular hot microenvironment benefited from the mosunetuzumab. So a lot of things from the molecular background to be seen in the future based into the molecular classification. How can we assess the response? We are assessing the response to intensify or de-escalate based into the PET scan. PET scan into the Goya study, it showed that it was a prognostic, not something that you interim PET. So those who had a PET negative compared to the PET positive showed differences in terms of the progression-free survival into the Goya study. One of the studies also it showed that the PET positivity as interim, the main concern with it is the false positive. And this is one of the study. For example, 38 patients, they had a PET scan which was interim and it was positive. But when the biopsy was taken, only 5 patients. So the bottom line, we cannot use the Duviel score nowadays as interim to guide treatment to intensify or to de-escalate. What about the delta mask, SUV? Delta, it means that the change into the SUV uptake from the baseline and into the interim. So they calculate the baseline minus the interim divided by the baseline. It will give you a ratio. Those who achieved a more than 77% reduction into the delta SUV, it showed to be a predictive of a response after 2 cycles. So if you're gonna use the PET scan to guide treatment, use the delta, not the Duviel score according to this data. This is one of the study where they used the delta SUV, and it showed a nice separation between the two groups that who had a response versus no response. But when the treatment was intensified, according to that change, when they used the Burkitt protocol induced with the PET positive disease, it did not show, and that makes sense. If those are not responding to the chemoimmunotherapy, intensifying with the same chemoimmunotherapy will not give a more benefit, but that was different into the Zuma study. So they used the Duviel score and they used the CAR T cell after R-CHOP or DOJ as the support, but this is just only a one study, and that's because of the maybe effect of the CAR T cell compared to the intensified chemotherapy. So those are the prospective studies now using the delta SUV change to intensify the treatment as interim PET. What about the minimal residual disease? They have a different minimal technique. They have the IG sequencing, the CAP sequence, or the VASED sequence. Those are all to detect the minimal residual disease during the treatment as interim or the end of the therapy. And it showed that those patients who had circulating DNA at the day 1, cycle 3 was negative. You can see the differences into the progression-free survival, 80% compared to a 41% for those either MRD negative or positive using the clono-seq as minimal residual disease. This is also the retrospective study. Circulating DNA was assessed after 2 or 1 cycle. If they have a minimal residual disease negative after 1 cycle, they call it early molecular response. If it's after 2 cycles, they call it a major minimal residual disease. And it showed that using the minimal residual disease can be used as a modality to maybe intensify or maybe not or to de-escalate. VASE2 MRD, this is the Glovi R-CHOP. So what they did in this study, they give 2 cycles of R-CHOP, and then they did the circulating DNA. If it is a high risk, and the high risk minimal residual was defined by less than 2 log decrease into the minimal residual disease, they consider it as positive and high risk. And they escalated to Glovi R-CHOP. So you can see the changes from the overall response rate after 2 cycles of R-CHOP. The CR was 60% and improved to 85% after adding the Glovi to the R-CHOP. So this is one of the modality that you can early detect which patient they might benefit from intensifying the treatment based into the interim or the minimal residual disease. The same data,
دكتور
sure, from the prospective frontline diffuse large B-cell lymphoma. Those are the ongoing studies incorporating the response adapted, so I will not go through these things. The ALPHA study also, one of the study after the treatment was completed and achieved a complete metabolic response on a PET scan. If they have a minimal residual disease positive, they escalate to a CAR T cell, so waiting for the results. So the last part is selecting the best treatment. We've talked about the POLARIX study. We have a data from a phase 2 about the bispecific into the induction. We've seen the CAR T cell in the ZOMA 12 and bispecific epcoritamab, R-CHOP, and also the GLUV. And now those are the running ongoing phase 3 frontline study. So bispecific, we have the SKYGLO with the GLUV, PULA, R-CHOP, the EPCOR, diffuse large B-cell lymphoma, epcoritamab, R-CHOP compared to R-CHOP, Olympia, which is the odrontuximab compared to R-CHOP, CAR T-cell is the ZUMA study, AXI, and then other targeted agent in the front line as the Tavalin or the acalabrutinib, and you can see the completion date beyond the 2027. So a lot of novel agents into the frontline treatment. So in conclusion, the cell of origin can guide the treatment, and we've seen the data from the POLARIX, the genetic subtypes, example, those with the cluster 5 and MSD, they might benefit from the novel agent as a BTK, and comprehensive use of a PIT plus the minimal residual disease will guide the treatment in the future to escalate or de-escalate. And we have to wait for a lot of the ongoing randomized trial incorporating the CAR bispecific and other novel agents. Thank you.